My name is Divya Shankar. Welcome to the Pathology series. Today I'm going to be talking about breast pathology and just mentioning a few words about breast pathology and the diseases associated, and a couple of tricks and tips to help you remember. Honestly, this is just going to be a really casual presentation, nothing super serious. So I just want you guys to get a good grasp of breast pathology so that it's useful for your future and useful for your exams. So let's get started. So here we have just a few, like the index, just to let you know what I'm going to be talking about. First of all, I'm going to be talking about the physiology of the breast to get the basics done. Then I'm going to introduce a few little words about breast pathology, talking about what diseases I'm going to be talking to you about, and a few words about clinical diagnosis of breast pathologies. And then after that, I will be swiftly moving on to inflammatory and benign breast diseases, where I'm just going to be mentioning main features and a very brief clinical summary on some of the diseases. And then moving on to the most important part, which is breast carcinoma. So I will be talking to you guys about the main 4 types of breast cancer, and I'm also going to be talking to you guys about hereditary and male breast cancer as well. So here we have the physiology of the breast. So the breast is actually a modified sweat gland, embryologically derived from skin, and the breast tissue can actually develop anywhere in the milk line, which actually extends from the axilla all the way to the vulva. So the functional unit of the breast is known as the terminal duct lobular unit, where it consists of lobules and ducts. Lobules make the milk and ducts push the milk to the nipple. So one thing that I really want to show you guys, here we go. Here's a nice picture. So here's the lobule. And within the lobule, you have these structures known as alveoli. And this is what we call luminal epithelium, the inner layer. Okay. So in the luminal epithelium, this is where milk is essentially made. So when milk is made, it needs to be pushed through into the ducts here. And the way in which that happens is you can see these green cells, these fibroblasts, and you can see these blue cells. I don't know if you can see these blue cells. These are the blue cells, actually are myoepithelial cells. And what they do is they can contract. And when they contract, they can push the milk through into the duct and steer the milk straight to the nipple, so that it can, so the baby can feed. So we say that the breasts are actually very hormone sensitive. So the development of the breast is actually directed by the estrogen and progesterone hormone, especially after puberty. So before puberty, what's actually present is like this duct, really large ducts behind the nipple. And that's found in both males and females. However, once estrogen and progesterone start cycling around in the body, that's when you have development of these lobules. So this is really important, this one phrase. The highest density of breast tissue is found in the upper outer quadrant of both breasts. So in the left side is the left upper quadrant, right side, right upper quadrant. And it's really important you guys remember, because most pathological diseases occur in this area. So a little introduction, just to mention exactly what diseases I'm going to be talking to you guys about. So I'll start off with the inflammatory conditions, where I'll mention a few words on acute mastitis, periductal mastitis, mammary duct ectasia, and fat necrosis. And we'll move on to the benign tumours and fibrocystic changes, where I'll be talking to you guys about fibrocystic change, intraductal papilloma, fibroadenoma, and phyllodes tumour. Then I'm going to move on to breast cancer, and I'll talk to you guys about DCIS, invasive ductal carcinoma, lobular carcinoma in situ, invasive lobular carcinoma, as well as a few words on hereditary breast cancer and male breast cancer. Before I get into it, I'd just like to mention a little bit of clinical pathology. because I just think it's really important for you guys to understand what exactly you're learning about, rather than just learning blindly from like information about histology. You want to know what the histology is actually doing. So breast masses are most commonly found in biologically female individuals, where it's most common to have young females presenting with benign masses, and the more older you get, the more risk of breast cancer you have. And the main two causes of breast masses is either increased hormonal sensitivity of the breast, or we have increased genetic predisposition for certain diseases such as BRCA1 and BRCA2. And I'll mention more about those two shortly. So typical signs and symptoms of breast masses. So breast masses can actually be completely asymptomatic. So breast masses can actually be found incidentally on mammographies, or patients may only have the symptom of, I have a mass, I don't have any pain, and it hasn't got any other implications like changes of skin or anything. However, we can have breast masses which present with change in appearance or size of the breast. So the breast can appear very swollen, tender, red, may even have some like rash present on the breast. We may even see some nipple discharge. We may even see some signs of skin puckering, or also known as peau d'orange. We may even see signs of change in nipple color. And these are all signs of, okay, alarm bells, something's going wrong. We need to see a doctor. So the way in which we can diagnose breast masses is, first of all, when the patient comes in, take a very good family history and personal medical history. We want to ask them, have they got any family with cancer? Have they got any mothers or fathers with breast cancer, or grandmothers? When did they have it? How long did they have it for? And if they died, at what age? We want to ask also some personal medical history, such as, are you on any HRT? Are you on any oral contraceptives? Do you smoke? Have you had any children? Did you breastfeed the children? These are very important questions which we need to ask to assess for increased estrogen exposure. And then after doing that, we would obviously physically examine the patient, where we would inspect and palpate. We don't percuss and we don't auscultate. So instead of the IPA, it's just IP. Inspect, palpate. And when we're palpating, we palpate all four quadrants in a smooth manner where we're rotating. A very good source to use is just YouTube. You can ask, I think Geeky Medics does a very good video on breast examination. Just check that out. And then we have the ways in which we can actually see what's going on is in postmenopausal women, commonly we use a mammogram, which is basically like, it uses x-rays, and you'll be able to see any signs of calcification or abnormalities in the breast. Or in patients who are fertile, we don't want to give them increased exposure to radiation, we can give them an MRI or an ultrasound. And once we actually see what's going on in the breast tissue, we can actually distinguish whether what it is exactly by doing a biopsy and assess the tissue under a microscope. So depending on what the breast mass actually is, we have very, very different types of treatment methods, which I'm not going to mention too in detail. So you can either observe it. So if we examine the tissue and we see, okay, it's not really necessary for us to do anything, we can just, keep an eye on it, see if it grows. If it grows, we can do some intervention. Or you can manage it surgically, where you can resect the tumor, resect the mass, or you can even do, in the case of malignancies, you can remove the whole breast tissue, wide local excision, or you can do a lumpectomy, quadrantectomy. However, if it's something that may need to be managed palliatively, or it's very large, we don't know if we got everything out in the right way, we can do other therapies such as cryoablation or radiation therapy, or even chemotherapeutic agents, which I will briefly touch on later. So that's a little bit about breast masses and how to manage them. But look into this more in detail in other sources, because this is only going to be about pathology. And as I forgot to mention, not a lot of them, but some benign masses of the breast can develop into breast cancer. So we always need to be aware of that. And I'll mention a few of them in this presentation. So I'm going to talk to you guys about the inflammatory disease of the breast first. And the four I want to talk to you guys about are acute mastitis, periductal mastitis, mammary duct ectasia, and fat necrosis. So it's really tough to find a mnemonic for you guys for this, but I'm just going to explain it to you as easy as possible so that you can grasp it through just understanding what it is. I'll start off with the etiology. So acute mastitis is basically a bacterial infection found in the breast, usually due to breastfeeding mothers, where their nipples get very dry and they start to form fissures and they crack and they bleed, making their basically, forming a infection pathway where Staph aureus specifically, or most commonly, can infect. Then we have periductal mastitis, which is basically inflammation of the subareolar duct. And the risk factor for this is smoking patients most commonly may have periductal mastitis, or relative vitamin A deficiency can actually lead to squamous metaplasia of the ductal epithelium. And when this happens, it causes the ducts to become blocked. And then wherever there's a block, most commonly inflammation arises. So this can lead to very inflamed breasts, which can present like acute mastitis. Then we have mammary duct ectasia, which is basically inflammation and dilation of the mammary duct. So the duct. And the main risk factor for this is the fact that the women are postmenopausal and they've had many babies. So they've had babies many times, multiparous. Fat necrosis is basically, says it in the name, necrosis of the fat found in breast tissue. Usually associated with trauma, but may not necessarily be associated with trauma. Can be due to some idiopathic causes as well. So in acute mastitis, the breast is very, very tender, very red, swollen, and may even present with purulent nipple discharge. And what we need to be careful about is where we see nipple discharge or purulency, we may be thinking about, okay, may lead to an abscess formation. So we need to really keep an eye on that. With periductal mastitis, the patient typically can present, because it's the subareolar duct that's affected, it can cause nipple retraction and subareolar mass. So we can actually be able to palpate some sort of mass found in just behind the nipple. And as I mentioned before, we can have, because of the vitamin A deficiency, the squamous metaplasia occurs of the ductal epithelium, which we'll be able to see upon the biopsy. Mammary duct ectasia, on the other hand, is present as a periareolar mass. So here's the nipple, and it's found outside of the areola. And these can actually be presenting symptoms can be green-brown debrotic or debris discharge. And upon histology, the patients have signs of chronic inflammation. So I'm emphasizing the word chronic. So someone might ask you, what are the differences between acute and chronic inflammation upon histology? Chronic inflammation, you will see lymphocytes or plasma cells. Okay, this is very important that you guys need to know the difference between acute and chronic. In acute, you will see neutrophils. Chronic, lymphocytes. Okay. Then you have fat necrosis, where you can basically, it's very tender. You can see a physical mass whilst you're palpating the breast. And when you take a biopsy, you'll be able to see areas of calcifications and necrotic fat and the presence of giant cells. So treatment-wise, a lot of the time, if there's signs of very acute inflammation or swelling, usually there's signs of bacterial infection, you can just give them some antibiotics. Or especially in a breastfeeding mother, we would actually encourage feeding. So basically encourage drainage of the breast. So we're trying to drain the breast of the bacteria. So we would ask the patient to encourage feeding or pumping, and give them antibiotics as well. So moving on to fibrocystic changes of the breast. So this is actually a very common benign disease, where we basically have development of fibrosis and cysts in the breasts. And it's typical in premenopausal individuals, and it's really associated with like the hormonal cycle of the estrogen and progesterone. So typically the ovarian hormones. And it also can be present as bilateral, I repeat, bilateral tenderness, and it can be very, very lumpy. So there are some specific characteristic changes which arise in the breast, which I'm going to show you guys here. So here you have like the normal breast tissue with the normal ducts or normal glands, and then you have the stromal epithelium here, or the connective tissue. So one of the main, or like the three main characteristic changes in fibrocystic changes is obviously the cystic dilatations with presence of microcalcifications. And surrounding these areas of huge cysts, we can have stromal fibrosis. So it becomes very cellular, the stroma. And we can also see some increased ductal proliferation or glandular proliferation, of which is also known as adenosis. So there are two main types of fibrocystic changes. We can have sclerosing adenosis or epithelial hyperplasia. Sclerosing adenosis, is basically when there's increased proliferation, formation of acini, as well as the increased stromal fibrosis. We may even see some increased signs of microcalcifications, and it has a very slight risk of cancer. However, on the other hand, with epithelial hyperplasia, we have increased number of cells in the terminal ducts or lobular epithelium, so here especially, and these cells can actually become very atypical. And when they become atypical, it's a very, very high risk, or slightly high risk, or quite high risk of developing invasive carcinoma. So if this tumor, or if this change is only associated with fibrosis, cysts, and apocrine metaplasia, like here, which are basically sweat glands, modified sweat glands, very low risk, or not even any risk associated with carcinoma. If we see signs of ductal hyperplasia and sclerosing adenosis, like this here, it can be double the risk of developing cancer. However, if we have signs of atypical hyperplasia, anything associated with atypical, wow, very high risk of developing cancer. So like it says in the presentation, 5 times the risk of developing cancer. So this typically can present as a lumpy breast mass, and found in the upper outer quadrant on physical examination, and it can be tender, like I mentioned earlier. Moving on to intraductal papilloma, where it's basically a rare benign fibroepithelial tumor which arises from the ductal epithelium, and it basically grows like a little cauliflower into the large duct. So it grows into the duct rather than out, like around the duct. It grows into the lumen of the duct. It actually is a fibrovascular projection, and it's lined by luminal cells and myoepithelial cells. So like, remember what I said, like the luminal cells are the inner parts and the myoepithelial cells are the outer cells. Okay, and here we go. I've got a little picture for you guys. So here is the fibrovascular core, and you have the myoepithelial cells here. It's quite hard to see. And then you have also presence of epithelial cells lining the fibrovascular core. They can present as the main symptom is basically a bloody nipple discharge. especially in premenopausal women. And we've got to be really careful because there's something else that can present with bloody nipple discharge, and that's papillary carcinoma. And the way in which we would have to differentiate between papilloma and papillary carcinoma is if we do a biopsy. And when we do a biopsy, what we will find in papillary carcinoma is that it actually lacks myoepithelial cells. However, intraductal papilloma has both. So that's the main difference. So intraductal papilloma has epithelium and myoepithelial cells. Papillary carcinoma has only epithelial cells, no myoepithelial cells. I just want to get that across to you guys. So we would definitely do a biopsy and check with histology and see what's going on underneath the microscope. So we're going to move on to a fibroadenoma, which is basically a tumor of fibrous tissue and glands present in premenopausal women. And it's very estrogen sensitive and is actually one of the most common benign breast neoplasms. It's very round, well circumscribed, and you can actually move it. It's not fixed like tumors, and it has a strict border, and you can actually like move it around in the breast tissue. And it's a very common or increased occurrence in patients who are less than 35 years old, so premenopausal women. So here we have, this is the stroma, because it has the fibro part always associated with connective tissue, so stromal part, adenoma, epithelial part here. So it consists of epithelium and stroma. And there's actually three main types of fibroadenoma, and they are basically giant fibroadenomas, which are basically adenomas over 10 centimeters in size, and it can look like a phylloides tumor, which is coming up next, and I'll talk to you guys a bit more about that shortly. Or juvenile type, and the juvenile type is basically when you have fibroadenomas with patients who are between the ages of 10 to 18 years old, and they have high amounts of glandularity and high amounts of stromal cellularity. So here the stroma would be full of cells, and there'd be loads of glands around here. Yeah. And the third type is complex fibroadenoma with proliferative changes. So these proliferative changes are basically what we talked about earlier with the fibrocystic changes. You can have sclerosing adenosis, calcifications that are present on the fibroadenoma. So complications can be increase in size, increase risk of infarction, inflammation, and mildly increased risk of breast cancer. Phylloides tumor is a very rare fibroepithelial tumor, which basically the name comes from the fact that the actual histology of this cancer itself has leaf-like projections. So the stromal part of the tumor, which has fibroblasts and stroma, both, grows in really chunky leaf-like patterns like this. Can you see? And that's why it gets the name phylloides from. It's leaf-like. And around the leaf-like projections, you have large glands present here, as you can see. Large areas of glands. These are generally benign. However, they can lead to malignancies, or they can develop into a sarcoma. As most of these tumors I've just talked about, like the benign ones, are most common in young premenopausal women. And with phylloides tumor, it can be associated with acquired chromosomal mutations, such as chromosome 1q. And these actually metastasize hematogenously and very rarely lymphatically. So when it metastasizes hematogenously, it can spread pretty fast, and we need to catch it quickly. So some signs and symptoms it's very quick growing. So it can present with or it can be slow growing. It can present as a very large, palpable mass. And like I mentioned before, it can be slow or rapid growing. And we can grade this according to the increased cellularity, the mitotic index, and the actual nuclear polymorphism. And one thing I want to mention is that, like I wanted to tell you guys about the fibroadenoma, the phyllodes tumor actually has a very cellular stroma, and most of the tumor itself has it's actually most of the tumor itself consists of pathological changes. Like there's very rarely like little bits of like normal parts of the tissue. It has a large component of the tumor. And it has increased cellular stroma here. Loads of cells in here. Loads of cells for the phyllodes tumor. So we're now going to move on to breast cancer. And I just wanted to mention a few little words about the basic principles and the etiology behind breast cancer. So breast cancer is actually the most common carcinoma in the women, second to skin cancer. And it's actually the second most common cause of death in women associated with cancer. And the main risk factor, or one of the main risk factors of breast cancer, is associated with increased estrogen exposure. And I'm going to give you guys my first mnemonic, or I think it's my second mnemonic. It's my second mnemonic, and I call it FOLA. So you want to follow how much estrogen the patient has been exposed to. And that is based on for female, O for obesity, L for long estrogen exposure, A for age, H for history. So you're following how much estrogen this patient has had. So basically, obviously, females females have more estrogen. Isn't that obvious? I guess so. And then also patients who have increased obesity, people with a lot of adipose tissue actually tend to store and produce a lot of estrogen. So that is why patients who have obesity have increased estrogen exposure or increased production of estrogen. A long estrogen exposure basically can be because of three things. Patient has started menstruating at an early age. Patient has never ever been pregnant, nullipara. Or patient has started menopause very late. So early menstruation, never been pregnant, late menopause. This can prolong how much estrogen the patient has been exposed to. Age, older the woman, the longer they've been exposed to estrogen. Pretty obvious. And then we have history. So history is basically based upon, are they taking any hormone replacement therapy? Are they taking any oral contraceptives? The pregnancy that I mentioned. Have they got any family history of cancer? These are all these are just a few of the history associated questions you should ask a patient who is suspected of having breast cancer. We can also subtype cancers, just a little bit of in-depth pathology here, associated with the type of receptors that are found on the cancer cells themselves, which we usually do via immunohistochemistry. And there are three main receptors which are found on these breast cancers: the estrogen receptor, progesterone receptor, HER2 receptor, and there's something we can check for, which is protein Ki67, which is mediates cellular growth in the cancer cells. And depending on what receptors are present on the tumor, we can actually target special therapy to eradicate the cancer via chemotherapy. And this is what I wanted to lead into, is prognosis of breast cancer is usually associated with TNM staging. And we always use TNM staging when we refer to any kind of cancer. And if you don't know what TNM staging is by now, I will quickly explain it to you. It's associated with the size of the tumor, how many lymph nodes, or where are the lymph nodes at, has it spread to any lymph nodes, metastasis, How far is it spread to? Has it spread to any other organs? Has it spread to any other lymph nodes? And then you got the predictive factors. The predictive factors is basically we're trying to predict how effective the treatment is going to be. And we can only predict how well the treatment is going to be based on if there's any receptors on the tumor which we can actually target using chemotherapeutic agents such as tamoxifen for these two and trastuzumab for this. Now, it's very difficult, very, very difficult if the tumor doesn't have any of the three of these. So when it doesn't have any of the three of these, we call this a triple negative tumor. And when it's triple negative, that's when it gets a bit tricky because it's not going to respond to tamoxifen and it's not going to respond to trastuzumab. So we've got to think of another way in which we can treat this tumor. And I'm not going to get into the nitty gritty of that. That's for another day or another series. But we can get into grips with the different types of DCIS and LCIS. So if you don't know by now, DCIS is ductal carcinoma in situ. LCIS is lobular carcinoma in situ. So I've got two pictures to show you guys. So here is a typical presentation histologically of lobular carcinoma in situ. So here you got huge amounts of atypical proliferation of the lobular epithelium. See how it's multifocal. It's not localized in one area. It's like got loads of big fat blobs everywhere. That is why we call LCIS commonly multifocal, okay? Because it has multiple focal bits. Whereas DCIS is ductal carcinoma in situ, where we have lots of atypical cells here with various differentiation or quite undifferentiated. And it's present proliferation within a duct, lots of central calcification and necrosis. And notice how it has not invaded the basement membrane. And that is what is key for LCIS and DCIS. It has not invaded the basement membrane. So let me get into the nitty gritty. Ductal carcinoma in situ is a malignant proliferation of ductal epithelium. And like I mentioned, it has not invaded the basement membrane. Okay, so if it passes through here, that's when it becomes invasive, but it hasn't. So that's why we say it's in situ. However, say this is the duct here, and there's a nipple, say like here. I'm trying to make you guys picture it 3D. So maybe if I can use let me see, pen color. Okay, let's use a red one. So here, this is like a duct which develops like this. This is a duct. And then here is a nipple. If this proliferates like this, proliferates, and it reaches the nipple, this is known as Paget's disease. So the ductal carcinoma in situ has basically spread through and extended all the way up to the nipple, and then it can actually spread along the nipple like this, okay? And that's what we call Paget's disease of the skin. Paget's disease of the breast, sorry. Histologically, we grade it according to the architecture, or describe it according to the architecture of the cancer. And we can see that there's really high grade cells here. Really, really high grade cells. And we basically can see how there's central areas of necrosis here, and there is areas of calcification. And this type of typical structure of the tumor is known as a comedotype. So we have high grade of cells here, we have areas of necrosis here, and central calcifications here. Okay, that's comedotype. And sometimes we can even have presence of microacini here, like it mentions here, or sclerosing adenosis. And these ones can present as a mass. And so these can be present in physical examination, or we can evaluate it or palpate it in physical examination. But it's a confirmed diagnosis is usually done via mammography. On the other hand, lobular carcinoma in situ is malignant proliferation of the cells of the lobules, and it does not invade the basement membrane. These, on the other hand, do not actually produce any calcifications like DCIS does. See, you can't really see many calcifications here. And because it's within the lobules, it's really hard to actually find a mass. Sometimes it doesn't even like produce a mass, and it's an incidental finding sometimes on a mammography. But if we do find something abnormal in the mammography, we take an histology, and we can maybe even see multifocal and bilateral lesions. So what I meant by multifocal, you can see here, loads and loads of blobs of cancer here. And usually can maybe be bilateral, so on both breasts. And we can say sometimes if we zoom in, I can't zoom in on this, but like if you zoom in, like in a microscope, you can see that the cells are sometimes discohesive, which means they don't actually stick together like here. You can see how they're all clumped together. Sometimes they're a little bit spread apart. And that can be because they're lacking this protein called E-cadherin, which actually helps cells to adhere to one another. And when that's not there, it's a problem. And I'll get back to this when we're talking about lobular carcinoma, invasive type. And like I said, if it's like an incidental finding, that basically means that they found it when they were doing a routine mammography for like patients who are being screened, like more than 40-year-olds be screened for like breast cancer. So that's why we have this screening, and this can be found incidentally, and we can take a biopsy. And that's DCIS and LCIS. And now we're going to talk specifically about invasive carcinoma, ductal type, which is basically invasive carcinoma, which arises in the ducts and forms duct-like structures and invades the basement membrane. So here we have the normal duct. Here we have DCIS, where we have atypical proliferation of the cells within the duct, but it's maintained within the duct. It hasn't crossed the basement membrane here. And now it has crossed the basement membrane. So this is when we say the cancer has become invasive, or it's the invasive type, where the cells are now invading into the surrounding stroma. Okay? So this is actually the most common type of invasive breast cancer. Over 80% of the cases associated with invasive cancer is invasive ductal carcinoma. And you can mainly check this out by seeing like there's a mass detected either in the mammography, or if it's too late, you can even detect it in a physical examination. And advanced tumors can even see, you can even see some signs of nipple retraction. So like the nipple is actually outside in, and signs of like peau d'orange or skin puckering as we know it as. And maybe changes of nipple color. And we would have to definitely consider this diagnosis. So these people would definitely need to go for a mammography. So the micropathology of invasive ductal carcinoma is basically they lead to formation of ductal structures within a desmoplastic stroma. Okay, and invasive ductal carcinoma can actually have 4 different types. So we have tubular type, mucinous, medullary, or inflammatory. My little mnemonic for this is MMIT or MMIT. So mucinous, medullary, inflammatory, tubular. Yeah. So tubular type is basically very well differentiated tubules. So they're very round, specific tubular structures, and they don't have any myoepithelial cells. Notice how anything cancerous doesn't have this. All right. So when it doesn't add this, it's most likely going to be something bad like this. Okay. So just watch out, and maybe that's one of the tips for you guys so that you can revise. Okay. Now we have the mucinous type, which is basically you have all these cancer cells and they're just surrounded by pools and pools of extracellular mucin. So it literally looks like the tumor cells under the microscope. I wish I had a picture. I couldn't find a good one. It literally looks like they're just swimming in in pools of mucin. However, it has got quite a good prognosis. So this can be treated. Medullary carcinoma are quite large, high-grade cells which grow in sheets, like on top of each other, and can also see loads of lymphocytes and plasma cells surrounding that area. And it looks quite similar to a fibroadenoma and has a relatively good prognosis. And this cancer is quite associated with patients who have the BRCA1 mutation. So ladies or gents who have the BRCA1 mutation, if they develop invasive ductal carcinoma, most likely maybe this type. And here we have the dreaded inflammatory type. And this one is a manic. It's bad. It's basically a carcinoma, like the invasive ductal carcinoma, but this one invades into your lymphatics. And when it invades into your lymphatics, what's it going to do? It's going to block the lymphatic drainage, right? When it blocks lymphatic drainage, your breast is going to be so full of lymphatic tissue, so lymphatic fluid and tissue. So it's going to be swollen, it will be red, it will be erythematous, and it can look like acute mastitis. So we got to be really careful and assess the history behind this patient, and definitely give them a mammogram, especially if in the case they may not be breastfeeding. We've got to think about, okay, it may be something bad, and assess the age of the patient. And this one has a really bad prognosis. It's a really, really, really aggressive tumor, because once it invades the lymphatics, it can really, really spread quickly to the rest of the body. So we have invasive lobular carcinoma, which I said I would talk to you guys about. These have no E cadherin. And what this means is these tumor cells just grow in a single file line amongst the stromal collagen or tissue. So it just grows like this. And they're quite undifferentiated. Look, every cell looks completely different. So this is what we call undifferentiated. Okay? And they're all different, and they're growing in a single file line. Some of the cells may have signet ring morphology. I think that might be one. I don't think I can see any signet cell morphology here. But yeah, it's typically, you know what the signet ring morphology looks like. But yeah, they grow in a single file, and these have completely surpassed the basement membrane, and they're just growing within the stroma themselves. And these are multifocal, can be bilateral, usually unilateral. But the most important thing is this is bilateral. This is a multifocal, and the previous type, invasive ductal carcinoma, is unifocal. Okay, that's just one thing we got to remember. So to end a little summary of breast carcinoma, I know it's been a very long one, I'm sorry guys, but we're going to just quickly breeze through and talk about male breast carcinoma and hereditary carcinoma. So hereditary carcinoma is basically when it's quite rare-ish, like 10% of the breast cancer cases are associated with some sort of hereditary factor. We would consider that the patient has hereditary cancer when we notice in the history they say, oh, like my grandma, my mom, and my sister all have breast cancer or had breast cancer. So that's what we mean by multiple first-degree relatives, someone like very close. We can say maybe it might be hereditary if they present very early on with an aggressive tumor, or if the patient themselves has multiple tumors. So say in the BRCA1 mutation, these patients can typically have both breast carcinoma and increased risk of ovarian carcinoma. So if they present with both types, then it's most likely, okay, they have ovarian cancer and they have breast cancer. We're going to have to check out like whether they have this gene, okay, this gene mutation. So a lot of the time, patients usually have, if they find out that they have the BRCA1 or BRCA1 mutation, they might opt for a bilateral mastectomy and sometimes even an oophorectomy or salpingo-oophorectomy. And someone famous actually did this, a very famous lad, or lass, I mean, And that was Angelina Jolie. I think she had this mutation. And she actually went ahead and did a bilateral mastectomy. And I think she had a hysterectomy and an oophorectomy as well. So that's because she actually carried this gene. So she went ahead and got rid of it all to try and minimize her risk. But there's always still a risk in case, the operation wasn't complete. But that's just a little something to help you guys remember hereditary carcinoma by. Just think about Angelina Jolie. Then we have male breast carcinoma. So male breast carcinoma is so rare, like literally 1% of all of the cancers. Super, super rare. And they typically are present as subareolar masses in older males. And they can present with nipple discharge. So a man comes in and he's like, I got a discharge coming from my nipples and I feel like I'm growing breasts. Okay. We may be considering either male breast carcinoma or we might be considering gynecomastia. And that we will have to distinguish between the history. However, if the patient says in his history, oh, I have Klinefelters or I have BRCA2, then we're going to think, okay, maybe it's more likely something associated with this. So just remember for ladies, if the BRCA1 is positive, they have increased risk of ovarian and breast carcinoma. And in males, it's more commonly associated with BRCA2. And I think that BRCA2, they're also associated with an increased risk of developing prostate cancer as well. So, thank you very much for listening. I'm really sorry it took a very, very long time. These are my sources that I used. These two are your bread and butter for pathology. Please use these two to the core. And if you want a really nice little pictorial source for breast carcinomas, definitely check this link out. It's really useful. And they had really nice pretty pictures, which I actually used in my presentation. So yeah, thank you so much for listening, guys. I hope this was actually useful and you guys learned something and I wasn't just sitting here blabbering. If you have any questions, feel free to get in touch with me. And all the best for your exams, guys. I hope you do really well. And thank you for paying attention. All the best.